For the next section, I'd like to invite up Dr. Petrosian and Dr. Robinson are already here. We're going to have a heart valve team discussion to talk about aortic surgery versus TAVR and controversial scenarios. So it's kind of an idea of like what we do on a valve center on a Monday afternoon. When we talk about the patients that we see, the surgeon, the cardiologist, the imaging specialist, we're all there together. So I'd like to invite Dr. Khan, I'm going to stay here, Dr. Khalik, Dr. Chung, and Dr. Berkey to all come join us on the stage.
Okay. We wanted to present two patients that in some ways are similar and other ways different, and we can look at what our recommendation was, what we ended up doing, and I think they're very interesting cases. So the first patient's an 80-year-old gentleman with hypertension, dyslipidemia, current smoker, sleep apnea. He's got some COPD. He's got an ascending aorta that's aneurysmal at 4.6 centimeters and severe bicuspid aortic valve disease, and he's dyspneic on exertion. His echo had normal LV function. He's got the bicuspid aortic valve, and on this echo, his mean gradient was 25 millimeters with a DOI dimensional index of 0.21, so consistent with severe AS. Lynn, is Lynn here? Or she's not here?
Omar's.
Omar, oh, sorry.
Yes, so, numbers in the moderate to severe range, I would say. So according to Philippe, severe. So pretty clear there. Okay, next one.
Okay, so cardiac cath, had some mild coronary disease. PFTs, some moderate restrictive lung disease, nothing terrible. And on CT, the aorta was a little bit more dilated at 4.8 centimeters, and some other non-critical findings.
So CT-wise, we have our annular area around 620. So that would be, and a perimeter of 90, so that would be in the large range for any of the transcatheter valves, the largest one. And then our sinuses are large on the right-hand image, above 33 to 35. And what you also notice is that it's a bicuspid valve, and the right and left coronary cusps are fused. So it looks like what we would call a Sievers type 1. So not a true fish mouth. There's a little bit of a commissure, but it's mostly fused.
So I just want to point out that at the annular level, which is on the left and 3 millimeters above, we're getting numbers, like you said, with an area-derived diameter of about 28 to 29, so on the big side. And
yeah, so here, so the ascending aorta is around up to 50 millimeters, so pretty large. And looking at other areas above the annulus, we continue to see the bicuspid valve. And this is one debate which we'll discuss here, and I'll also have a few slides in my talk. But so here's modeled a 26 or a 29 millimeter sapien. So one of the questions is with the bicuspid valves, since there's not 3 leaflets, do they anchor further above the annulus as well? And is this an area that we need to measure?
right. And so on the middle panel is as Omar said, is the virtual demonstration of a 26 millimeter valve, and on the right is the 29. And one of our concerns was there's that bar calcium on the image on both at about 6 o'clock, and you can see on the 29 millimeter valve, the concern was that calcium would push potentially the valve further out and cause potential complications.
Yeah, so on the middle image, you'll see that in one direction it looks like it's too big, and the other direction it looks like it's too small. It's not going to fill up the space in the commissure. So from kind of, let's say 11 o'clock to 5 o'clock in the middle image, it looks like it won't fill up that space, and that could lead to paravalvular leak. The concern George is describing is in the opposite direction, where potentially the bicuspid portion of the valve could be injured.
So,
I'm sorry.
go back. How would you grade the degree of calcification in this valve?
So it's not too severe. I mean, the leaflets look mostly thickened. So I would call this mild to moderate calcium, actually, with more fibrotic thickening of the leaflets. And one of the things we repeatedly see is that on echoes, things that the people call calcium are usually not always calcium, because on echo you can't differentiate, but on CT you can differentiate very well whether it's fibrotic thickening or true calcification.
So you would say this is mild, moderate calcification, more fibrosis?
Correct.
Okay.
The other thing to, sorry. Hello? Yeah, the other thing just to point out is that this is 9 millimeters above the annulus. So it's at the upper end of where you're going to seal. So the skirt of, a 26 valve ends at about 10 millimeters. So you're really looking very high up above the annulus here when you're looking at sealing. And the 26, as Omar pointed out, there is a gap. So that's something that I would definitely consider in this patient.
So here we have a little bit more of the clinical history. So this patient's STS score which is the 30-day mortality risk, was approximately 3 to 4%, but was increased significantly to approximately 14% with frailty. Newell, you want to comment on the aortic size and the index and how you use that?
All right, so to bring this into the context of our discussion as a team, and what are the concerns? So we have an 80-year-old patient, has some COPD. His risk score calculated is 3 to 4, but it's increased incrementally by frailty. The decision is complicated by the fact that this is a bicuspid valve. I'm not going to get into a lengthy discussion about what we know about treating bicuspid valve disease, but there are ongoing trials to determine the safety and efficacy. Early markers in the clinical trials indicated a slight increased risk of root rupture and an increased risk of stroke and transcatheter valve replacement. So that's the setting in which we're talking about a patient like this. The complicating factors in terms of the decision is he also has an ascending aorta that is 5 by 4.6 centimeters. There is a known entity of aortopathy associated with bicuspid valve disease. And if you were looking at this from the ACC guidelines, he meets the criterion for not only aortic valve replacement, but also consideration of replacement of the ascending aorta due to the risk of aortic rupture. So that's the setting in which we're making a decision, transcatheter treatment versus surgical treatment.
So, and just for the audience, just, in general, you can correct me, but, 5.5 centimeters would be a number for considering surgery as a rough guide in a typical patient with bicuspid disease, as Dr. Robinson was saying, would be closer to 5, and then...
No, actually, the guideline is 4.5.
If you're having a procedure.
If you're having a procedure.
So is that STS risk score for aortic valve replacement, or both AVR and ascending?
So that is calculated for AVR. But there are incremental factors in this case that would drive the decision. So it really is in terms of what I had brought up with Omar. It's like if a patient has a severely calcified valve, then the incremental risk of the transcatheter procedure increases due to the risk of displacement of calcium into the aorta itself.
Newell, do you have any longitudinal data about how his root got up there? In other words, the rapidity of...
We don't. We didn't have that.
Didn't have that?
No.
Okay.
So Newell, how much, I know you said that ascending replacement is not included in the risk score. So from your gestalt, how much extra risk does that portend?
I think it's, well, we'll see in a moment. But
other
certainly in a patient this age, you have to factor in the incremental risk of an aortic, ascending aortic replacement, and that risk would be substantially higher in an older patient with COPD.
Another question is if this patient had a TAVR, would that decrease the risk overall if you just needed to do an isolated ascending aortic aneurysm repair?
That would increase the risk, but because we know that with re-op, in re-op situations with transcatheter valve, it would depend on the choice of the valve. If it's a sapien valve, it's a little bit easier. If it's a self-expanding valve, core valve, then the frames of the valve itself extend up into the aneurysm, and that's an incremental factor that increases risk of reoperative surgery.
Because you'd go all the way down to the sinus to replace. I mean, you'd replace from the level.
You would,
yeah.
You would be replacing at least from the sinotubular junction up to the arch of the aorta.
Okay. So what
But I think in cases like this, you have to pick your battles, and so.
So this patient's SDS score with incremental variables increased to about 14%. So we made a decision to treat him with TAVR despite the aorta being dilated. You can see he's got a decent amount of aortic insufficiency at baseline. We ended up going with a 26. We were worried about the 29, causing potential root rupture, despite the annulus being in line for a 29 valve at the annular level. This is the rapid pacing and the sapien being deployed, and great result. We typically want these to be high, like right at the annular level, which is where we got it, and no aortic insufficiency, and Omar, post-TAVR.
Yeah, so I think the pre-gradients, mean gradient was around 30 with a peak velocity of 3.5. And from the aortogram, we saw some of that was likely from AI as well as AS. So we have reasonable gradients. I mean, for tricuspid disease, the mean in the trials is around 9-ish. For me in here, it's 13, which would be in line with doing a TAVR on a bicuspid valve. So I think a very good result hemodynamically.
Yeah, sometimes if the valve is a little undersized, we add volume on top of the normal volume when we implant an Edwards valve. Did you add any volume?
We did not. We went nominal.
And I remember that decision to go nominal, and I had to wear an extra pair of pants.
Which ones?
I know you looked at me like I was crazy.
Yeah.
It worked out fine. All right.
I think for this, before the next one, I think just to go back to Kristen, what she said about the shared decision making. This is a guy who, if his family goes to Google, if they read about this, everything about his case is going to tell his family and everybody else that he should have his aorta replaced at the same time. And that's where getting the surgeon and the cardiologist and the imaging specialist and everybody together so that you can explain to the patient, we think it's too risky to put you through having your aorta replaced, your valve replaced, your chest opened. So we're going to give you a TAVR that's guaranteed going to make you feel better, but you still have a risk of this aorta in the future, whether it gets bigger, you need an operation, or there's a risk of dissection or rupture. So it's all really important to have the group together so that you can sit with the patient and answer their questions so they understand what they're getting and what the risks are both ways.
So before you start, I'm gonna throw out Robinson's rule and for transcatheter therapy. And it hasn't changed in about 10 years. It's due to change as soon as we have more long-term data in terms of longevity or durability with respect to transcatheter valve. Robinson's rule is what, Kristen?
Over 70 TAVR?
No.
No.
How many times have we talked about this? Okay, Robinson's rule, the closer you are to 60, the better off you would be with surgery. The closer you are to 80, the better off you would be with TAVR.
All right.
Okay.
It's, Kristen, it's like
Kristen's
background
rule.
noise. You tune it out after a while.
Cut to the chase, okay? All right, so that's Robinson's
Yada,
rule.
yada, yada.
Okay, go ahead.
All right.
I mean, if, you know, if that patient even was 70 and a low-risk patient, I'd be pushing for the patient to get surgery. I mean,
Which
I think
patient?
You know, the case we
previous
just,
patient.
yeah,
Yeah.
I mean, I think,
With the aorta,
you know,
you mean?
with the aorta, with the bicuspid, and, I mean, I think I'd be pushing for surgery.
The tongue roll.
We'll let him battle it out. So the next patient
I think
is,
that's a good idea.
the next patient is interesting because in some ways similar, although considerably younger at 68, but some of the same anatomical issues, but again, variations, and we ended up with a different recommendation. But here we go. So 68-year-old man with hypertension, dyslipidemia. It says chronic systolic heart failure. Actually, his LV had declined in the last year, about a year, 12 to 18 months before he had normal LV function. Now he's got heart failure. He's got an EF of 25 to 30%. He's got a right bundle branch block, and he also has a dilated aorta and severe bicuspid aortic stenosis, and he's dismixed. So just one point, the right bundle is important because when we look at our data, our permanent pacemaker rate, all TAVRs, is somewhere between 6 and 7% now. We looked at our pacemaker rate if the patient has a pre-existing right bundle branch block coming in for TAVR, and it's about 30%. So it's important in terms of patient expectations, family expectations, that there's a very high likelihood they're going to need a pacemaker. This patient, again, as I mentioned, had an EF of 25 to 30%, severe AS. Omar?
Yeah, so this one had a similar mean gradient to the last case, but the difference here is the EF's quite low. So with a mean gradient of 30 and a velocity of 3.6, I would call this very severe aortic stenosis with this ejection fraction.
Thank you. On cardiac cath, he had single vessel disease with an occlusion of the right coronary artery, nothing significant on the left system. And he had some moderate pulmonary disease, not severe. And let's see, I think this we can skip, this the CT findings. And here are our CT images.
Yeah, so at the quote true annulus, we have derived diameters of 29 to 30 in the annulus and LVOT. So you see on the lower two images, as opposed to the previous case, this is what we would call a type 0 bicuspid, so a true congenital 2-leaflet valve, 2 sinuses. And the dimensions of the short axis of this sinus level, we call the intracommissural distance at 4 millimeters above is 30, so very large as compared to the previous case.
One of the concerns we had looking at these images was the extent of bulky calcification.
So you see on the annular image at the bottom, like 6 o'clock, there's something there at the annulus and LVOT, but also in the lower right image in the sinuses and the mid-leaflet, there are very bulky areas of calcification. So this would be severe calcification as opposed to the previous case, which was more fibrotic.
So based on our team discussions, based on his age of 68 years, LV dysfunction, the dilated aorta, and also the unfavorable calcification on the CT, we recommended surgery for surgical aortic valve replacement and aortic replacement. However, the patient was adamant that he wouldn't consider that. So we decided to go ahead because he needed something done, although we advised him that the short-term risk of major complications was not low, particularly based on the calcification distribution. Omar, you want to talk about that? Sure.
So here we're a little bit higher up at the leaflet, 9 millimeters, and we're modeling the two transcatheter valves. So
26 on the left, 29 on the right.
Higher up on the 26 valve on the left, actually the intercommissural gap from 11 to 5 seems like less compared to the previous case. But what's striking is the very, very severe calcification. So, looking at the right-hand image of a 29 being modeled looks very scary to me.
Yeah.
Something that would be a very high risk for injury.
Right, and based on the size at the annulus, it would have been that size valve, but we went with a 26 for all of those reasons. We talked about that. Here's our procedure. Again, some aortic insufficiency. Here's our valve going in. And really, really good result. So just a whiff of aortic insufficiency. And this is our post-echo.
Yeah, so I think similarly to the first case, so a mean gradient about 14, which is a good reduction from the baseline, and a good hemodynamic result for a bicuspid valve.
So that was it.
So let's go back to,
You want to go back?
yeah, I just want to go back to this slide with the calcification.
Sorry.
Right. That.
This one or the other one?
Yeah, the other one. We've seen that and this one. So, we got away with it. Let's put it that way. You got a good result from the perspective of aortic valve disease. But when we've seen this kind of calcification, these two large pieces of calcium, especially with a bicuspid valve, what happens, in my opinion, or what can happen, and what has happened to us, is that one large piece of calcium is perhaps involved in some fibrosis, is rigid. The other large piece of calcium becomes mobile, and it can, and that's what results in the rupture of the root of the aorta. Is that rigidity of the valve, and the larger piece of calcium is pushed out and pierces the root of the aorta and cracks. So it didn't happen in this case, but we have seen this happen. My only thought about this is, yes, we did what was right for this patient, because he wasn't going to accept any treatment unless we did this. But there's still this discomfort of making this decision that we had, and we were repeatedly trying to convince him that the complete operation that he would tolerate was a better operation.
So one thought was, we've discussed valve sizing. What thoughts did you give to valve type?
Well, I think the easy answer is what I alluded to before, is that that's a large aneurysm. He's 68 years old. He might be back. And it's going to be an easier, not that it's going to be an easy operation, but it will be easier with a low-profile valve than a valve that's traversing that. And the other aspect of that is that in a large aneurysm, you have to be concerned about a self-expanding valve that has the height that it does of actually piercing and causing an acute dissection at the time of implantation.
So for the audience, what Dr. Khan was referring to is that in these two cases, we used Edwards balloon expandable valve. The other valve that we use often is a Medtronic self-expanding valve that's made out of nitinol. There's no balloon on it, and there are certain advantages and disadvantages to each. There's also recently approved, Abbott has a Navitor valve that just got approval fairly recently that's also self-expanding. Do you guys want to make a comment about any preference on balloon expandable or self-expanding based on bicuspid valves?
Yeah, with this much calcium, I mean, the Edwards valve it's a balloon expandable, so you're actively pushing the valve when you're deploying. The Medtronic valve is self-expanding. It has a little bit more of a passive deployment, and we see various anatomies and cases like this, minus the aortopathy. I think a lot of us would have considered a self-expanding valve in hospital anatomy like this.
Philippe, what would you have done? Do you want to jump on the mic? The mic behind you.
So how low the coronary were? Whoops.
Yeah. That's on.
Okay. How low the coronary? Is the coronary height was low or
No,
was high, right? Yeah, it's a tough choice. I think both valves could be good here. I think the problem with those patients, we see this all the time, they don't want surgery. If they don't want surgery today, they're not going to want surgery in 10 years. So, I think we just treat the patient the best we can at the moment. I think bicuspid is probably the most challenging case that we do. You would like to cut those leaflets. For me, when I look at this, I would love to split those leaflets, the right, the left, to make it tricuspid-like, and then you put a big valve. You can do with surgery, electrosurgery, or you can do with the blade. But for now, I think this type of case, we will have used probably a self-expandable valve because of the amount of calcium. But I don't think we have a clear answer because this type of valve, if you put a core valve in, you can have the post-dilate, which is almost like a balloon expandable. So we're still debating those, So I would say the first case, I will have go with a 29. This one, I tend to size like normally. I don't undersize. But I think this case, I think you did the right choice, obviously. You cannot argue with success. But I think there's probably two ways to do this. I like the delicate way. If the patient is very frail and older, I would go with self-expandable, 68. I think you're okay with a balloon expandable.
Yeah, I think I agree with Philippe on the first one. I also would have gone with the 29, but the 26 was successful as well. So a lot of these have overlap zones, not only between the sizes, but the valve designs. One of the other hopes is that as we treat more of these, that there will be valves specifically developed for bicuspid, which I think would be a more ideal solution.
Dave?
One question and one comment. Is that on? Yep.
Yeah.
The question, did he get a pacemaker or not?
He did. He got a bi-VAICD. That's EF was low, but a week later his EF was normal.
Oh, really?
Yeah. So that's good to know.
Yeah.
And then the second is sort of, these patients, we all know that every patient, if given the choice, would choose a TAVR because they want their easier recovery, they want to be home quicker, they just feel that that's a safer and easier procedure. Where, do you draw the line on like, this is just the silliest thing ever to, offer these patients a TAVR? How fervently do you say, really, you're making a very bad call here, and I'm not going to do that. It's a difficult position, I know, as taking care of these patients. But talk us through kind of that discussion and sort of what the patient's ultimate rationale was and why you thought, okay, we can support this.
I think if you look at our data, you showed national data with roughly a 1% in hospital mortality, and that's our numbers as well. So if we're faced with a patient like this, and we told him his risk was higher, so if we multiply it by 5, and I told him that, I said, I'm telling you that I think your in-hospital mortality could be 5 times what's average, could be 5%. He goes, I don't care. So, at that point, if you think there's a 95% chance of success and the patient understands, I think it's reasonable to go ahead. If you've got a 60% chance of hurting the patient, I think it's a different story. So,
So maybe I can say to your answer, Dave. So we had a 57 years old guy, same anatomy like that, type 0. He's a basketball player, who pretend he is, but and he was animate that he doesn't want surgery. So we met with our surgeon. And I said surgery is the best option. And now he started to shop around with small program. He got offered TAVR in a very small program, and he called me and I said, listen, this XYZ operator want to do a TAVR on me. I said, okay, let's come here. We're going to do the TAVR. But I think people will shop around. This is what's going to happen. So I prefer to do it in a high volume center with good backup, with surgery in the room, and you can always, sometimes you can't convince those patients, especially the active one working, they need money and they cannot stop for 3 months. So the other thing I will say is this case is great because the cornea were high, so you have to plan, can we do a second TAVR in? So this case, because the cornea were high, I'll say core valve is fine, sapien is fine, because you can probably put another one without. So I think now without occluding the cornea. So I think now we're planning the second and the third procedure by choosing the valve. Initially, we're thinking about what can I do in the second procedure. So I think this is what is changing. So.
Thank you. Okay. All right.
Yep. No, I agree. You asked for a comment?
Yeah.
No, I agree, and I think what Dr. Generou said makes a lot of sense. And we had one slide that I've seen, and I know Chris presents about all the programs in the area. And if we sit and have a discussion with the patient, the thing that she also mentioned about the mall, I was on call one weekend and walked around the mall here, and it was for a different program, but gigantic billboard over the atrium in the mall. This was several years ago. This is before there were, the data we had, the numbers we had, and we're still the biggest program in the area, but there were, the other ones were much smaller. Now everybody's doing a ton. And when I saw the sign advertising TAVR, I thought, no patients are going to come in and want to have surgery anywhere. And so when it comes down to it, if we explain everything to them, like Dr. Petrosian mentioned too, and they understand the risks and the benefits, if we don't do it, which there have been patients, we will say this is not the right thing to do, and we stick by it. But the vast majority of them could get a TAVR instead of surgery. And if we don't do it, they're going to get taken care of.
Yeah.
Because somebody will do it, and it may not be good for them, because they may end up at a small place where the place just wants to have another TAVR on the list. We're not looking to people to sell TAVRs because we want the numbers to be higher. We have a good program and people come to us. So I think, as long as we understand and the patients understand, it all goes with that decision-making. Sometimes the shared decision-making is the patient who disagrees with all of the doctors and we're all on the same page, but they're they're the biggest part of their care and the biggest part of their decision-making.
Just one other thing, we can't separate the human element from the decisions we make. Omar, in response to your comment about, the 29 valve, there was a case we had done probably a few weeks before that we didn't expect to have any anatomic complications that had a root rupture. Not through and through, but so there's no question that you're influenced by the cases you just did, so.
Okay.
Yes.
I have a question. As a clinical cardiologist, like I am, on the first case, the 80-year-old gentleman who, with the bicuspid valve, who has an ascending aorta already meeting the criteria for surgery,
Right.
who had a TAVR, how would I follow that patient in the office, in terms of measuring the aorta? When would you recommend elective repair of the aorta? At what size? Right?
Yeah.
What change? He already meets the criteria to start with, so how would I follow that patient?
That's actually one of the reasons why I asked if there was some, previous information, because if it had been that diameter for 5 years at that point, I think you'd feel a lot better leaving it alone than if they had a previous CT or transesophageal echo and it had been in the 4s.
So from the surgery side, if somebody came to me, because I see Dr. Robinson went out of the room, if somebody came to me and had a TAVR but had an aneurysm like this, and I didn't have much information, rather than a CT every 6 months for the first couple of years and then spacing it out if the aneurysm doesn't grow, I would probably get one in 3 months and then maybe once or twice during the year. The cutoff, if you don't have another reason to go into somebody's chest, is 5.5 centimeters. So this guy who was 4.6, if he had a TAVR and it was already in, my first question would be, why do you have a TAVR and they didn't do an operation? And he would say, I didn't want one. And then going ahead, if it got to 5.5, you would follow him. Even if it's below the cutoff, If an aneurysm grows a centimeter a year, despite being less than 5.5, that would still meet our indications to fix it. So I would surveil him and follow him like a normal patient, and my recommendation probably would fail with him anyway, because he said if he didn't want surgery now, he's not gonna want one in a few years from now, but that's the way I would treat him.
Use 5.5, although for bicuspid valve, normally 5.
Yeah, it would be less for a bicuspid, but
Just use 5.5.
the truth is for him, he already refused, and so I could say really you should have surgery because now it's 5 from 4.6 or 5.1. The likelihood that he's going to sign a consent and go is probably not great, but if it gets to 6, 6.5, you may have a little bit more chance of getting him to change his mind.
I understand
Yeah,
his views.
his view, right.
When do I approach it?
I would remind him every time you see him that you kind of still meet these indications, and I don't want to hear that you ended up in the emergency room with, or didn't make it to an emergency room because of a bad problem.
I think we have another question over here.
Yeah, my question is regarding a patient like this with a very heavy calcification. What's the time to root rupture? Does it happen during surgery, or do you have to, does it come later
No, it's
post-op?
usually at the time of the procedure, 'cause the patient will present with, hypotension, typically tamponade, and that's been our experience, I think, is that it's usually right away.
So once the patient survived the surgery, you don't have to
Correct.
like
Correct.
survey or anything like that?
Yes.
Okay.
Good?
Ready to go on?
I think so. Are there, if any other questions? Okay. Thank you, everyone.